welcome everybody. This is our inaugural session. Rebecca McEwen and I are the Ontario Health East palliative care co-leads. So maybe Rebecca, if you can say a bit about yourself.
Hi, everyone. My name is Rebecca McEwen. I'm a nurse practitioner practicing outside of Kingston. I've been in long-term care as an NP for the past 5 years, and prior to that was a director of care and an administrator. So welcome to you all.
Yes, so this is palliative care for long-term care clinicians presented by long-term care clinicians. So I hope this is quite enjoyable. Let me just move my, oops. So I'm Ben Robert. I'm a family physician in the Ottawa area. My practice is in South Keys. I'm the chief medical officer at Pearly Health, which is a large long-term care home. And a member of the Ottawa South Palliative Care Group. I've been doing long-term care since the turn of the century. And it's come a long way. So I'm pleased now to sort of co-host, if you will, or host some training sessions for everything long-term care. For those of you who aren't quite aware, we do have quite a slate of people to talk throughout the year, from cardiac to renal to pulmonary, and so on. All these people have experience in long-term care. So I like this slide. It's a slide I took of the Milky Way and in Bolivia. And you know how in the Western world, we look at constellations as the bright stars, and we make sense out of that. Interestingly, the Inca made constellations out of the dark spots between the skies. And all that is to sort of, make people curious, because we can see things and we can see the same thing with a very different viewpoint and still be sort of talking about the same. So just a few polling questions. MRP is most responsible physician. MRNP is most responsible nurse practitioner. Medical director is primarily for those who do primarily medical directing and no attending. And then other, I'm just curious.
And I set it up so that there'll be a number of questions going sequentially. When you answer the first, I'll bring you to the second, and then the third, and then the fourth. Okay, I think that's most people then. So what we can do now is end the poll and share the results. Do you want to read out what the results are, Ben, or do you want me to?
Could you please?
Okay, sounds good. So for what role do you have? Looks like a mix of people, but 46% of people, so 12 people said MRNP, and we had 3 people, 12% saying MRP, 8% 2 people medical director, and 9 people, 35% said other. So if you're other, maybe you want to let us know in the chat what other is for your role. For the second question, how many residents are under your direct care? We had 5 people, 23%, saying less than 20. We had 3, which is 14%, saying 20 to 40. We had 2, so 9% saying 40 to 60. And we had 12 people, 55%, saying 60 or more. And no people saying that they're a manager administrator. For how many homes do you work at? We had 13 people, so 57% saying 1, 22% saying 2, 17% saying 3, 4% saying 3 or more. And for the last question there, have you had palliative care training? Looks like a real mix of education people have had. 19% said no, they haven't had any. 57% said LEAP, so that looks like the most common here, with 24% saying they got extra training in residency or NP experience, 14% saying ECHO, and 24% saying other.
Okay, so quite the mix. I'm pleased to see that we have people with a broad range of experience. That'll make the questions quite good. Okay, and so whenever you see the Milky Way, it's because I'm doing a transition. Having the first sort of introductory session, I'm a bit of a disadvantage. So what I've done for to put things together is I'm trying to look at some of the issues that will be factors for all of the following sessions. So I'll look at some of the legislative issues, and then we'll move on to frailty. And frailty, I think, is a key sort of concept to understand for people who work in long-term care, because the vast majority of our residents have some degree of frailty. And last, I'd like to talk about cachexia, which is something that we'll see towards end of life in the terminal phases of chronic diseases. So in the context of legislation, we have the Fixing Long-Term Care Act 2021, which was a tweak of the previous Long-Term Care Health Act. But the idea behind the new one was to improve staffing and care, to have the medical services up to date. So there's annual training, and to put in place some mandatory committees and certifications. And what we've noticed with that as well is that a palliative approach to care has been legislated. It's the first time, and I believe we're the first jurisdiction to have that in legislation. Now, some of the things that are also have been tweaked. So there's mandatory programs through the through FLTCA, or Fixing Long-Term Care Health Act. Many of the mandatory organized programs have been expanded, but there's also mandatory interdisciplinary programs, and these are programs that are to look at specific issues that are more likely to occur in long-term care. And then finally, there's a few pieces that tell you how to practice. For example, you need an annual physical for your residents. You have a time frame for which to do admissions, and so on. There's the Residents' Bill of Rights, which some of the other institutions do not have. And generally speaking, we have to follow these bills of rights, rights. So the issues are people need to be treated with respect. All of these make sense. People have a right to be informed and participate. And so this is a bit different than what we see in the hospital. In the hospital, you can offer treatments and just start the treatments. There's not that right to participate in your treatment decisions to the extent that we have in long-term care. So what is palliative care? I thought we'd start with that. And so World Health Organization defines palliative care. And in my case, I'm just calling it TLC because it matches well with LTC. So palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with a life-threatening illness. And so that's very good in some worlds, but in long-term care, I'd like to just change it a tiny bit so that people are getting the approach in the context of problems associated with a life-limiting condition or with life-limiting conditions, because typically that's what we see. We see a whole bunch of conditions occurring at the same time, impacting on the person's quality of life. So that's the framework behind which we're working in long-term care. So when we look at frailty, according to the Canadian Frailty Network, it's defined as a state of increased vulnerability with reduced reserve and loss of function across multiple body systems. And this reduction also reduces the ability to cope with normal or even minor stresses that then cause rapid and dramatic changes in life. And so, when we talk about palliative care, frailty is really, you could call it the F word in palliative care because there's no specific thing. And when you that you're focused on, it's a whole system. And so it can be the lungs, the heart, the liver, the kidneys. These are the big ones, the brain as well. So dementia has a big impact on frailty. But people forget about muscle loss, and they forget also about the frailty that occurs with the skin. The skin is one of the bigger organs, and as people get older, as the skin becomes more and more frail, the connective tissue is not as bouncy. The dermis is not as thick, and as a result, we have a lot of pressure points that weren't there before, that is basically due to frailty. And so when people describe frailty, a lot of them focus on you have the frailty and then look at all the areas that it impacts, from being institutionalized to polypharmacy to delirium and so on. I would like to also mention that some of those arrows should go inward as well, so that if we have fragility fractures, that increases the frailty. If we have too many medications, that increases the frailty. And being institutionalized also increases your frailty. So how do we measure it? I'll go through this very quickly, but there are a whole bunch of measures from the Prisma 7 questions, and these are yes/no questions. And if you say yes to more than 3, you're defined as fail. So one of the questions is, are you over 85? Another one is, are you a man? Because these are all predictors of frailty. Walking speed, this is quite easy. Just see how fast people walk. And time to get up from the chair and walk 10 feet and come back is another way. You can have a self-reported score. You can examine the person. And for some people, just having 5 medications or more is a sign of frailty. And then finally, there's an indicator questionnaire that's sometimes used in research, the Groningen frailty indicator. And this one is essentially quite a few questions that are also yes and no. What I'd like to introduce later is the scale that I think is easiest to use in my mind, and is also Canadian made. So when you see the frailty, basically this dotted line is somebody who is frail, and you have an acute event, and occasionally they recover, but not to where they were before. But they very quickly fall below the line that sort of defines whether they can be independent or dependent. And so this is the Clinical Frailty Scale, or CFS, developed by Ken Rockwood out in Dalhousie. And basically, the reason I like this is simply because it offers a picture for families to understand where people are at. So the big majority of people, certainly in my experience, who come into long-term care are severely frail just at the start. And so they need assistance with most of their ADLs. At the same time, people don't appreciate that they're at high risk of dying within 6 months. Occasionally, I do see people who are moderately frail, and this sometimes gets confused in the context of people with severe dementia, where they simply need help with some minor issues, such as queuing for eating or for bathing or other personal care. But if you look in the right-hand corner at the bottom, you can see that depending on the severity of the dementia, the dementia in of itself determines your level of frailty. So if you have a severe dementia, you'll be considered severely frail. So if you can't do any personal care without assistance, including queuing, that puts you in the severely frail, even though you are walking about with perhaps a walker. And this is just to remind people where frailty fits. Basically, when we're down here, the fact that you're admitted to long-term care, and once you move in, that by definition would put most people, not everybody, we do have some younger population now, but most people would be considered severely frail. And so this is important. The scales are so this is Coach Shaw. Maybe I should yeah, would I recommend the scale versus the fast scale? I would just use whatever scale you like. The importance for me in outlining where the frailty is more that the families understand, and this will become a little bit more clear later on in the presentation. And so when you have people who move into long-term care, 1 in 3 are severely impaired. 46% have aggressive or behavioral issues related to their dementia. More than half have some kind of musculoskeletal diseases. And so when you look at all these things, you realize that people coming into long-term care, have a whole bunch of comorbidities, and that's how they sort of get the frailty, if you will, or end up in that category. An easy way to look at frailty is frailty is vulnerability. So if you're vulnerable and you have a stressor, you're more likely to have a bad outcome. And so one of the ways I've found that families understand frailty is I imagine people who are severely frail have a very, very overloaded canoe, such that there's probably just about 1 inch or so or two between the water line and the top of the gunnels, the freeboard, if you will. And that weight is the weight of conditions, the weight of experience, the impact of disease, maybe the number of medications. And so when people are young and when they're not frail, that canoe floats high, and it can withstand a lot of wind, withstand a lot of waves. But as people sort of become more and more frail and the canoe starts getting more and more overloaded, that reserve to withstand small winds, small waves, begins to become much, much less helpful. And no matter how strong your canoe is built, right, if it's floating low, you have a tough time meeting challenges. And so one of the difficulties we have in long-term care is prognosticating, because a lot of it has to do with when does the next health challenge occur, right? Because that canoe, however loaded, if it's floating on very still lake water, it's going to float for a long, long time. The question is, how will it cope with a small headwind, with small waves, and so on? And that explains as well some of the necessary things that we do, where you start medications very slowly, you move things very slowly, because if that canoe's overloaded and you're doing a lot of movement in there, you're going to take on water. So we're changing topics. So from frailty now to sort of see how we can do in getting a sense of prognosis, because all of this in the context of a palliative approach to care is trying to identify people who think that, when do you think people will start benefiting from that approach? So if I can ask you to just consider, Doris Mencia. She's a 77-year-old immigrant from Italy. She's got dementia, mixed dementia, congestive heart failure, and is oxygen dependent. So she can walk to the dining room, but very slowly, and needs to stop at times. Her blood pressure is well controlled. She's dependent for all independent activities of living, and requires cueing for most. Even though she can do stuff on her own, she needs to be reminded. And this has been increasing over the past few months. And she's had recent admission to hospital for congestive heart failure. So just in the chat, if I can have people put in, what do you think her prognosis is? And I know your name's going to show up, but don't worry about it. It's just you have to put a number to it, and we'll go from there. So we only have one answer, and I know that there's more than 20 people. You will not be graded. There's no right or wrong answer. Just put something down. So I'll be talking about some prognosticating tools. One of them is the Proactive Identification Guide from the Gold Standards Framework. And actually, if you Google PIG Gold Standards Framework, this will come up. And basically, it looks at many of the issues from an organ basis and from a frailty basis. So if there's a general decline, these are some of the issues that will inform upon frailty. Specific disorders, so if you have specific organs like heart disease or COPD, then there's neurological disorders. I only show the first page of 2, but it's quite good. Another one is the Supportive and Palliative Care Indicator Tool, or SPICT for short. It follows much of the same format. And I do believe that some of the hospitals are starting to use that in their health record to help identify those people living with frailty. And it's important in the context of, how do people die? And so where long-term care is very different than sort of oncology is that with cancer, people tend to do well until the treatments fail. And then there's a rapid, relatively predictable drop in function. So predictable that the PPS score, the Palliative Performance score, is actually somewhat correlated with prognosis. So a PPS of 30 means that you have a very short, weeks to many weeks of life left. Typically what we see though is the red line, the chronic disease line. And with dementia and frailty, we see sporadic and intermittent sort of decline. And because many of our residents have both, we can sort of see how things are. And so I've done this to exaggerate because basically some of the drops in functions, right, are so deep that we have many, many times where I've been sort of thinking, no, this person is not going to survive this minor health challenge. And because they've changed so much over a few days, so I start my end of life order set just in case, and lo and behold, they sort of gather their forces and perk up. So a lot of the times, when is the right time to start medications? When is the right time to sort of call family? Very, very difficult in long-term care. So back to Doris. We talked about the prognosis. Okay, is this Carl? Did you have this in the poll?
Yeah, I can run it now.
Yeah, let's do that.
Okay, so there's the results. It looks like it's kind of split between people saying under 1 year and 1 to 2 years.
Okay. Okay, thank you. One of the tools I prefer is called the Respect tool. It's available online if you Google Respect and then Big Life. Several reasons I prefer it. One, again, being a proud Canadian, it was actually developed in Ottawa. And it uses data that we collect when people receive home care at home. And with that data and using specific algorithms, it's able to predict prognosis at a very, very accurate level because it's been tested with hundreds of thousands of people. And so with Doris being 77 years old, the average lifespan for her is roughly 2 years. Okay, so 50% of people will be dead by 2 years, and 25% will have died within 8 months. And again, 25% of them would have survived past 4 years. So it's really quite difficult to prognosticate very clearly. Now, if she were 83 years old, so just 4 or 5 years older, suddenly 25% of people would have died within 4 months. Okay, so if we if I have 10 Dorises coming in, and I'm going to have 2 or 3 die within 4 months. So here I am, people are feeling guilty that they're moving into long-term care. It's a new team, and in my experience, a lot of people have not been told their prognosis. And so this is quite the shock. And so in my mind, if we're able to allow families to understand just how frail the families are, that would be great news, especially at an earlier time. And so when you look at this is why I think COVID was so difficult, because the vast majority of people have a gradual increase in disability. And so in the hospital setting, you could see that rise in disability quite quickly. So it's easy to anticipate where people are going to need palliative care. It's easy to identify. Most people in long-term care are in this persistent severe disability where they're already at a very high risk of dying. And the surprise to the other health sectors came about when COVID breached the Atlantic, because I was not surprised that we had a mortality rate as we did. And as it turns out, our mortality rate was very similar to other countries in the world. It's just that we have so many people over the age of 80 institutionalized compared to other people that it looked like it just skewed the numbers towards long-term care. And so part of the reason that people have difficulty is that, when you have a cancer diagnosis, there's a beginning, right? You are told you have cancer, and now people are starting to think about mortality right away, right? And the treatment calendar, your social life with doctors starts to increase, and with care providers. But when you don't have a beginning, right? When you have, like, for example, congestive heart failure, where it's a progressive thing. It gets worse. And every time you get worse, you recover partially. And people still tend to remember what they could do as opposed to what they can now do. And the thinking is, I hope it doesn't get worse. Other illnesses become difficult to sort of cope with. And so this is what makes prognostication and identification much more difficult in people with frailty. And so points to remember, in Ontario, 1% of the population dies annually. But in long-term care, roughly 50% of the people will die within that year. And so to put that in perspective, by the time I'm finished talking, that 16 people in Ontario will have died. And so right here, when you look at the dark line, this is the line that clinicians understand where the person is going. But unless people are told that how frail they are, the gray line is actually where they think they are. And so this disconnect, this gap here, is why there's so much sort of shock and so much unhappiness when people are told late in the game that they don't have a lot of time left. And this is not new information. If you check down here, this is in 2000, right? So 25 years later, we're still faced with the same gap. And so, when we start prognosticating, there's a certain comfort level, and I could see that in the chat, where people weren't quite sure and things. And so one of our greatest barriers is that our ability to prognosticate is actually inversely proportional to our relationship with the resident. So they're coming in, and we don't know how they've done, right? It's past sort of health challenge, how they reacted to it. It will predict very well how they do for further health challenges. A lot of people are worried about being wrong. A lot of people then sort of think about, maybe I underestimated things. And the reliance on tests in the context of frailty, so looking at a number versus looking at the person is one of the things that clinicians should try to stay away from. Focus on the person. And most people want to discuss and learn about end-of-life issues, but at the same time are not doing it. And so I'm arguing that the very fact that people are filling out a health assessment form for long-term care actually sort of identifies them as being very frail and late in life. And so the hope is that when people understand this, that when you look at the Health Quality Ontario sort of quality statements, their first statement is people with a serious illness have their palliative care needs identified early. And I'm sort of saying, again, we're focusing on illnesses. I just sort of focus on conditions. And so early identification for most of the people, I would say, occurs when they're actually admitted to long-term care, when they come in, and perhaps even on filling out the form. I've heard, but I haven't been unable to corroborate, but here in the Ottawa area, over 25% of people who have applied for long-term care die before they actually get a chance to move in. And so if that's not sort of a sign that these people required a palliative approach to care, I don't know what more should be done. So now we'll go towards a concept called cachexia, which I think is important. I spend a lot of time explaining to families early on in people's stay about cachexia so that when it does come, it's not a surprise. And now for those of you who play Scrabble, cachexia, that's 22 points. And I'm not including any kind of bonus squares. So when you look at the cachexia, I really want to emphasize that it is not starvation. And when you look at the diseases that are associated or the prevalence of cachexia, you can see that COPD, congestive heart failure, renal disease, liver disease, over 30% of people with these conditions have some form of cachexia. And so I like to describe it a little bit along the lines of, Thanksgiving is coming. Imagine being invited to a dinner, and the food is excellent. And so you really have had your full, like you really can't eat anymore, but now the host insists that you have another serving. And so, if I'm eating that turkey, it's not gonna taste as good. It's not gonna go down as well, and I'm probably gonna feel worse having eaten that little extra. And so people with cachexia will get that sensation earlier on in the meal, oftentimes after a few bites. The other component of cachexia has to do with a preference for diet texture. So if I'm not feeling well and I go down to the dinner table and there's chicken or steak to chew on, I might just push it a bit to the side. And if there's shepherd's pie, I might poke around a bit with the ground beef or maybe with the mashed potatoes. If I'm really not hungry, I'm going to sort of have a bit of butterscotch pudding or creme brulee or something like that. And finally, maybe just some soup broth. And so that preference from a regular diet to minced to pureed to thickened fluids and finally fluids is the second component to cachexia. And it's really important because these two are independent, right? And cachexia in chronic disease is very different than cachexia in cancer, because people can start having cachexia in chronic disease and live a long, long time. And so how does it show up? Well, it shows up with a diet preference. It shows up with gradual weight loss so that you're now adding in supplements, right? And so once you need supplements in order to maintain weight, you know that cachexia has started, right? And if the family is aware, they're getting gradually sort of conditioned to the thought of, yes, this is the beginning officially of the end. I identify cachexia, particularly in people with dementia, as sort of people are entering the terminal stages of dementia, simply because now their body is gradually starting to shut down. And again, just a reminder, with starvation, people suffer when they're not eating because the body is trying to survive. Whereas with cachexia, people suffer when they are eating because it's part of the dying process. And all the organs are being impacted, right? So you may not have as much acid produced in your stomach. And if you're on a PPI, even less so. The intestines aren't moving. They're not absorbing things as much. The liver is not metabolizing as well. And we know that indirectly through liver function tests, where you can see that people's albumins, their cholesterols, their INRs start changing just because of aging. And so, it's not just the things progressing. It's just that if you overeat, you do get symptoms, and you're not actually going to be absorbing the food. And so again, a reminder about, we talk about a palliative approach to care, but really if we could focus on the quality of life aspect, right? Because when you're trying to sort of focus all your care on what matters most, that really talks about quality of life. So on the days that we're not dying, right, that's when we should be living as best as we can. So the key points here is, timely identification. Frailty has a huge impact. Now, there's the RESPECT, the gold standards, the SPECT. There's a bunch of other tools that can be used to sort of give signs that things aren't as healthy as they could be, or that things are vulnerable. The trajectories are unpredictable. And so what does that mean? Well, it also means that if you're focusing on goals of care, most of my goals of care are not medical, right? It's important for somebody to be able to eat and spend time eating. So they go to the dining room a little bit earlier. They go back to the room a little bit later. It's important for them to have to play bingo. These goals of care, so getting somebody down to bingo pain-free so they can enjoy it, is what these goals of care discussions are all about. Okay, so this is just a wrap up now. I left some time for questions. What's new to us is the Ontario Palliative Care Network, along with Ontario Health, have a new person coming in for long-term care and other places called clinical coaches. And you may have heard of them. If not, you will. And the purpose of the clinical coach is to sort of guide homes, in our case, because it's long-term care homes, in the delivery of healthcare services according to how OPCN, or the Ontario Palliative Care Network, would like it to roll out. And so these coaches will teach, mentor providers allow them to sort of build on their own programs. And then once people are able to do things independently or no longer need the coaching, they move on to another home. They're palliative care experts, coaches and teachers, but most importantly, they deal and help you sort of get things going. So they're a change agent. And oftentimes they'll provide some community support and connections. So who are they? Here's the list of them. And so with their emails. So I'll let you write it down if you want, or actually review the whole thing and hear my voice for another full hour on the YouTube channel. For the physicians on the call, if I can just remind you that if you do a small reflection exercise based on what you've heard today, when you apply for your credits, you can link learning to practice. So when you put in your CME thing, you'll see just as you click OK, up pops a little drop menu that gives you a choice. So just go click to learning, and the questions that you have to look at. So I'm giving you a cheat sheet, right? So you can think about this right now. Is when they're asking you to link it to learning, you consider the source. So this is the Ontario Health East palliative care group that's through Val Fizette that's helping us there. So trusted source. I've given you other sources, right? Some of the training that you can do. How do you appraise whether there's information? And then how will you apply these changes into your practice? And then 6 to 12 weeks later, so essentially, Remembrance Day to New Year, somewhere in that time frame, you just go back to your reflective exercise. You write down what you've learned, and then you submit it. And for that amount of work, you get an extra 5 accredited credits. So Main Pro Plus. So just reminding you that these sessions here, and are quite valuable in the context of CME, as long as you're able to sort of change how you do things. So questions? I left a good 15 minutes for questions. You can't leave me high and dry. So maybe I'm going to introduce a bit of my conflicts of interest. Those of you who, here's a question. I'll finish my thought and then I'll answer the question. Those of you who are members of the Ontario Long-Term Care Clinicians, so I am the past president, okay, and I've been on the board for some time, but there is a conference in the last weekend of October in Toronto that is very, very useful because it's everything long-term care. So to answer the questions, when do I present these things? I do it super early. I do have an interest in dementia care, but this approach applies to most care. And so I start the conversation with the families at the initial care conference. And I spend usually somewhere between an hour to 90 minutes. And I know it sounds extraordinarily long, but the amount of time it saves later on, the amount of angst that families no longer have makes it absolutely worthwhile. So I do front end load my work. And, at the, when people have been with me for 4 or 5 years, they've seen the decline that I've predicted. And, they feel much better about the care that's being given. And so so I present cachexia to families, much like I just presented it to you. And I do it again at the first care conference, even though there might not be any present. So I talk about, in the initial care conference, I talk about the conditions, where they're at now. I see how they've reacted to previous hospitalizations. And if the families were aware of the loss of function that occurs following any hospitalization, with dementia, even moving from one home to another always results in a drop in function, both cognitive and physical. So part of the reason I talk about cachexia is just to let them know. And many family members also appreciate their grandma or great grandma is not eating as much, and she's been eating less and less over many, many, many months. So now they have an explanation as to why she's not eating as much, right? And with the fluid stuff, it's important to recognize as well that our thirst mechanism starts to deteriorate after age 50. So if you're 65 and you're drinking when you're thirsty, you're almost certainly always dehydrated. And so dehydration is part of the dying process. And when people actually stop drinking, I let families know that, they typically it's expected that they're going to pass within 7 to 10 days, but often within 2 or 3 days. The exceptions are people who are fluid overloaded. So people with congestive failure or very severe pitting edema. So yes, cachexia is related with sarcopenia in the sense that there's various ways that the muscle mass can decrease as people become more and more frail. They're less and less mobile. But as the body is starting to sort of eat less and less calories, the muscles also use up a fair amount of calories, and when they start to die off, they don't require as many calories either. So they are interrelated. So the cachexia and sarcopenia are interrelated, but I really don't know whether it's a cause and effect or just a strong association. Are there key triggers or criteria? Whenever there's a big change in condition, and I see one of these things, which I actually should have put in my slides. And one of the ways I like to prognosticate for families to also give them a heads up is, when I start seeing changes from 1 month to the next, if these changes continue, I expect months to many months of life left. If I see changes from 1 week to the next and they continue, I expect weeks to many weeks. And if I start seeing changes from 1 day to the next, then I'm looking at days to many days. And so this is where it makes it difficult, because when somebody has a mild viral pneumonia, and they're changing from day to day, I'm expecting, if the changes continue, I don't expect to see them with my next weekly visit. But if they hang on and recover and the changes stop, then we go back to, if I see changes from 1 month to the next, they have months to many months. And so that because when I work in the hospital and people start deteriorating, I see those changes, and it's really difficult to prognosticate because I use the same rule of thumb. But as soon as they go to long-term care and it's more quiet, it's not 24-hour hustle and bustle, and people can eat at their speed. People are actually lifting the trays so that people with dementia can eat, and so on. Oftentimes, people will bounce back a bit, and you can understand, from my perspective, understand how the hospitalists made their prognostications, because it's so difficult in the context of chronic disease. It's not like cancer or other diseases that have a very sort of predictable trajectory. So what criteria? If there's changes, I always, whenever there's a conference of any kind, so usually at the annual, I bring it up again and again and again, year after year, because oftentimes when people have a hospital visit, and I've predicted that's going to be a drop in function, perhaps a drop in cognition. I've predicted it at the initial conference, and they see it occur, and then they see the partial recovery. Over time, they recognize that maybe a transfer to hospital might treat the condition, but it actually makes the person worse. Is there anything that can make the cachexia a bit better for the resident? So with cachexia, I think the way I look at it is, it's part of the dying process. So I'm not quite sure how to make it better because the body is not absorbing the food. So you can trick it into accepting more calories through the supplements without making people feel poorly, but you're not actually affecting the actual process. So to your answer, I think that food preferences are key, and many people actually prefer the supplements. But if they like crunchy foods and the supplements are cutting their appetite, then families don't have to pick the supplement. They can pick the crunchy food that makes life better. How can homes get in touch with the coaches? I will defer that. If I can, you can send me an email. You can send Rebecca an email. So it's our first and last name. So in my case, it's Benoit Robert. So let me just change my name so you can see. Or actually, I'll put it in the chat. Rebecca, can you put yours in the chat?
Absolutely. And I saw the other question about whether or not there's a cost to the coach, and no, there is
No.
not.
I missed that question. Thank you. So it's our first and last name at ontariohealth.ca. I go by Ben because everybody gets my name backwards, either intentionally or unintentionally. So I get it a lot less often when I just go by Ben. Any other questions?
How do you react when families respond to you bringing up palliative care and they immediately think that their loved one is going to die soon? That's in the chat.
So yeah, I like that question actually. I talk about a palliative approach to care. And I mentioned to people that, on TV and in the hospital, whenever people talk about palliative care, it's typically because you have days left. And say, this is not TV, this is not the hospital. But when you look at a palliative approach to care, if your grandma is diabetic and she wants that extra piece of cake, right? Are you focusing on the cake, or are you focusing on the fact that tight control of sugars has no long-term benefit, right? And so when you focus more on what matters and less on conditions, that's a palliative approach to care, right? And so again, I guess some people didn't catch on, but if you flip it on the other way, instead of calling it a palliative approach to care, it's a care approach that focuses only on quality of life. Okay, that's all we're focused on, quality, right? You have symptoms, we'll see what we can do to get rid of them. You have wants, we'll see what we can do to have you get those wants. And we'll focus less on tight control or on issues that matter less than what you want. And that's why those goals of care, in my experience, are more about what people want to live well rather than how many medications are on and so on. Now, it could be that tight blood pressure control or tight congestive heart control allows them to do what they want. But at that point, again, the goal is to make people live well rather than to live long. And I think that's a key thing because, many guidelines fail to accommodate for the frail elderly, right? So finally, they're starting to do that. We have guidelines now that suggest that, with diabetes, that sliding scales in long-term care should be relatively contraindicated because the risk of hypoglycemia and falls and so on in that reactive sort of hospital approach model actually does not improve quality of life because if you have a sliding scale, you're getting picked, right? Although, yeah, nowadays there's a freestyle, so you don't necessarily get picked, but in the past that was the case with hypertension, right? The guidelines, the targets are now a little bit higher. With bone health, you look at the guidelines, and once you start getting into the frail elderly, most of the guidelines are groups consensus with not so good evidence, right? And so you sort of go, okay. so when you focus on all these sort of how do people live well, you know, that's the approach. Well, thank you, everybody. Hope to see you all next on November when Dr. George Heckman will talk about heart issues.
Great, and there's a post a session evaluation link in the chat.
If there's other things that you'd like to see, I haven't read the evaluation, but Carl, is there a spot for open things? So if I can ask you to look at the sessions that are coming up, and if there's anything that you have a desire in particular to hear about, you might be able to put it in now, and that way we can influence some of the speakers before they develop their slide decks.
Yeah. Yeah, there's a few different places you can have comments, but there's one specifically for topics that you're interested in hearing about.
So again, I get my conflict of interest with the Ontario Long-Term Care Clinicians. There's always talks on palliative care there. There's always talks on serious illness conversations. And this year we're piloting a course, we're calling it LTC 101. For people who are new to long-term care and some of these sort of things to sort of be wary about. We're growing this gradually so that eventually it could be a full day course, fully accredited and so on. But the idea here is to make sure that people understand the nuances of long-term care medicine because you know, when I work in the hospital, it's fantastic. I have same-day blood tests, same-day X-rays. There's nursing 24/7, you know, with a very high nurse to person ratio, none of which we have available in long-term care. And so the approaches are very different. The thinking is very different. You know, I order monitoring tests well ahead of time. And again, you just tweak things gradually. So that's available coming at the end of October.
Sounds good. Well, I hope to see you all at the next session.